giving away 2,500 money straight into your Loop account, and you haven't done what we have asked you to do, which is download the Loop app, or if you've already downloaded and registered, just do a transaction and send us a screenshot of a transaction from your Loop app, whether you're transferring money, whether you're paying someone, whether you are receiving money, or whether you're putting money into an account. Do something, okay? There are very many things that you can do with the Loop app. Please interact with it, see what works for you. In some cases, you may find that, this is giving us too much information. You can just describe. Go onto our DMs on Spice FM KE on X and tell us, this is what I've been able to do with my Loop app. I have been able to link my card, which was on this account, to this account. I've been able to transfer and make a payment to somebody who I needed to make a payment to. I've been able to actually transfer using either the NCBA account. I've done EFT, I've done RTGS, I've done PesaLink, because you can all do all those things. I've done my mobile money transfer. Or I've applied for a loan and I've received a loan. Or I've been told this is how much I qualify for as a loan. Any of those things, and we will give you 2,500 straight into your Loop account at the end of the show. Make sure you do that. The other hand is, if you want some 3,000 shillings worth of airtime, we want you to just tell us about how the Safaricom Home Fiber has transformed your life. It transforms life in very many ways. You have access to internet wherever you are. Maybe it's your office and you've subscribed to the Safaricom Home Fiber, or it's at home and you've subscribed to Safaricom Home Fiber. Particularly you've noticed the change in speeds, because we've been talking about the change in speeds recently, that the speeds are now much faster, depending on whatever package you take. Whatever package you take, Safaricom has decided, we are increasing the speeds, and those speeds are much higher. Tell us how that is impacting you. 3,000 shillings worth of airtime could come to you at the end of the show. Siti, remind us the day's proverb.
Yes.
And Dr. Mohammed will remind us his interpretation of that proverb, which is actually very, very good.
No, his interpretation is excellent, actually.
Mm-hmm.
If you are told a dog had run off with your ear, would you run after the dog or first search for your ear?
My interpretation is don't just listen what you are told. First, you have to find out what is it that you are being told before you take an action, whether it's true or not. So you understand for yourself, and then now you can ask for clarification and accept the message and the messenger, or dismiss.
Okay.
Yes.
So the new payments into SHIF.
Yes.
2.75%
yes.
of your gross income.
Yes.
Okay?
Yes.
So a friend of mine here called Andrew says, I will pay 10,000 shillings a month.
Yes.
To this SHIF thing.
Yes.
And yet and only be entitled to 950 shillings dental.
Yeah.
Or 1,000 shillings optical.
Yes.
Surely. 10,000 shillings a month.
Yes.
120,000 shillings premiums a year.
Yes.
And what I'm entitled to is 950 for dental.
Okay.
1,000 for optical.
So there has been a lot of issue on the issue of benefits and tariffs. So there is one thing that we need to understand when you are designing a benefit package for a UHC program. What you look at is what is the severity of this condition? What is the catastrophic nature of spending in terms of money that the person needs to spend on? Then what is the available resources? What is the disease burden? So that you are able to say, this is the basket that we have, because this is a social health insurance. This is the basket of resources that we have, and this is the problems that we are facing as a country. Then what do we need to prioritize that will help people from not running into challenges? So there is someone who's paying 10,000. There is someone else who's paying 300 shillings. So these two will be in one basket, which is 10,300. And now you need to provide services, which is equivalent to this 10,300. And that's how you come up with the benefit and tariffs. But more importantly, is for Kenyans to realize it. For the first time, they can actually participate in designing that benefit and tariff, because we have a benefits and tariffs committee established under the regulations that has civil society representation, has provider representations, has the DG, has the ministry CS appointee, has SHA appointee, only one seat, has experts in health economics, has council of governors appointees, and then allows individuals and associations and groups to petition and say, we have seen this, and that needs to be gazetted, and the benefit and tariff to be reviewed after every 2 years. So
there's one cadre of individual missing from that group, an expert in costing.
A health economist.
A health economist is not necessarily an expert in costing, but
Yes.
anyway.
Yes.
Go on.
Yes.
Yes.
So you have, there's an actuary from the SHA.
Okay.
SHA's representative is an actuary.
Is an actuarist.
Yes.
Go
Yes.
on, then you've
Yes.
answered my question.
Oh, okay.
Yes.
So that way, now you can petition and say there is a disease that you have forgotten, or there is a procedure that's missing from your benefits and tariffs. So that's how we have come up with the current benefits and tariffs. To be honest, dental was not part and parcel of NHIF benefits. Ever. It was, but for the few chosen ones.
How did the few chosen ones get chosen to have their teeth represented?
Because they were the so-called managed schemes. And who did it belong to? It belonged to people who are currently in active employment in the three arms of government, or who have retired from those three arms of government. So they were the only ones who had dental and optical. The rest of us Kenyans did not have those things.
So essentially they arranged preferential treatment for themselves.
Yes, they had a preferential treatment because they had what is called managed schemes.
Okay.
So, and that's why, so that people understand, when you see a lot of backlash, we said we don't want under SHA to have preferential treatment. What we want is everyone to have the same benefit and the same tariff.
Let me ask a question.
Yes.
If you say that 10,300
Yes.
is what forms the basis on which you will provide the service.
Yes.
All right. The reason why people have access to other services is often a question of what they're willing to pay in addition.
Yes.
NHIF was at a point where they even had similar services.
Yes.
There are branches of government that had these managed schemes where you paid more
Yes.
than what other people were paying,
Yes.
but then you were given more services.
Yes.
Right?
Yes.
Now, this committee that you mentioned that SHA has,
Yes.
what are they going to be considering? Are they going to be considering something similar? Because there's a basic service that everybody gets.
Yes.
What about if somebody wants more and they're willing to pay for it?
You go to the private sector. We allow you to go to the private sector. And this committee is not for SHA. It's at a university. Based at a university, secretarial services is provided by the Ministry of Health. You just need to look at other regulation. Now this is what they do. That committee receives petitions, looks at what has been in the tariff, what has been the benefits. They look at the basket. They look at, and they say, how is the uptake that we have had over the last few years. So the other thing that we need to realize is, what is it that we need to prioritize as a country moving forward? And that's what now that committee will be looking at and saying, We have received this
Which
petition.
diseases do we?
Yes, which diseases is prevalent, which is the one that's pushing people into poverty. Because I don't recall if you have ever been called for Harambe for dental procedure, ever. Extractions. So you see, but you have been called for someone who needs transplant, because that is a huge burden to individual and to families. So that is the prioritization that this group will be doing, that they will say, this is what we can, and it has to be sustainable. So they will look at the amount, what we have in the basket, and what we can offer as a service.
From your math,
Yes.
and even with your actuaries,
Yes.
what's the average highest amount that you're going to be receiving from individuals? There are, of course, those that are going to be on 300.
Yes.
There are those that are going to be on 20,000, like Andrew, my friend.
Yes.
But where is the median?
The medium is around 600 shillings.
600 shillings a month.
Yes, that will be the average that we will receive from the majority of Kenyans, because that's what is the premium that we will receive from. But what I want us also to realize is, this is the other thing that the public needs to understand, that if only people who have chronic conditions pay, and the young people say, I'm not interested, or I am employed. You are employed formally today. You can be fired tomorrow. Retrenchment can happen easily. Today you are paying 10,000 as your premium because you have a salary.
Yeah.
But tomorrow you don't have a salary, and you might be ending up paying the 400 shilling as your premium, or 500 shilling as your premium. So everyone needs to pay. If I am a dialysis patient and I pay 500 and it's 6,000, and if we are a million of us, we will pay 1,000 of us even, we will pay 6 million shilling only. 1,000 of us, 6 million. Do you know how much that your 6,000 can't even cover one session for dialysis? Just one. And this is your annual premium. It can't cover one session. So meaning you need more people, another 1 million people maybe, to pay 300 or 6,000 each. Then you have a basket now that can say, okay, we cover the person who is suffering from kidney conditions,
Right.
and we cover the person who needs surgery,
Right.
and we cover the person who has cancer, because those are catastrophic expenditure diseases,
Dr.
and
Ali,
very costly.
Why is SHIF paying for chronic conditions?
Why is SHIF?
Paying for chronic.
That is the one.
Why
that,
would SHIF be paying for chronic? I thought we have 3 funds that are
yes, yes,
One of those funds
Yes.
is the Chronic Critical and Emergency
yes,
Care Fund,
yes,
which is exchequer funded,
yes.
not coming from SHIF.
And now this is where now Kenyans need to help us in terms of resource allocations. So the Emergency Chronic Critical Illness Fund was not meant to be the first payer. So you have contributed, you have done your 2 or 3 dialysis sessions, you need extra session. Now the chronic comes in. You have undergone radiotherapy, 4 sessions, you have exhausted from your basket of SHIF. Now you need extra. Previously, what was happening is you are supposed to go back to your pocket. The reason why we have set up the exchequer-funded Chronic Critical Illness Fund is now this one steps in and says, Eric has exhausted his chronic disease treatment, but the disease is not yet over, or the treatment is not yet over. He needs few more sessions or few more interventions, and that's where now the chronic critical illness was supposed to step in. So for this current budget, we haven't been allocated enough. And that's
How
where we
much do
started.
you need?
For this one, we can take up as much as possible. even 100, 200 billion, because you don't want to limit people's extra, because in terms of diseases, you don't know. Yes. So, but the estimated amount was around 80 billion.
Okay.
Yes.
Take us a little back.
Yes.
Is there a place or a space in which biometric systems feature in this rollout that we're speaking of?
Thank you. I wanted to address, I had already even written it. So there's no place for biometrics in the current system. If you are an adult and you have a national ID, you will use your biometrics that you had given during your registration for your ID. That's what now the system pulls. That all you need is, you just say, this is my national ID, whatever number it is, and the system will be able to pick that from NRB, the National Registration Bureau. So the people who will need ID, the biometrics, are dependents who are above 7 and 18, in between. But for now, once you declare them as your dependents, OTP is enough. So for adults, you don't need biometrics.
Okay.
That's why we have one single source of truth. Eric does not become CT overnight because he has given his fingerprints in another system, in another database, so that you don't have many databases with different fingerprints. We just have one. We identify CT because CT has given his biometrics long time ago.
But Dr. we do already have the problem that you've just mentioned we don't have.
Yes.
If you are in Maisha number, it's a new set of fingerprints, blah, 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 blah. If you're in Huduma number, it's a new set of blah, 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 blah. If you have the old ID, which I have, you have it blah, 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 blah. Now Schiff comes along and says, it is unified, it is one. I'm going somewhere with this. Part of the problems that we are talking about, and it's problems with systems. We say that NHIF had a certain system, okay? People had been trained in it. SHA has come with another system, okay? People have been trained in it, I assume, okay? Now, is there reference to the transfer of data from one system to another? Why is this? Why am I raising this issue? Because one of the things we keep dealing with in this country is the employment of spirits. They are called ghost workers. And they exist. And part of the problem that NHIF seem to have is the same problem that the education system has. Money is deployed to institutions that don't exist, students who don't exist, NHIF, patients who don't exist, ailments which don't exist. So the moment you have multiple sources of identification, that problem doesn't seem like it's going to come to an end soon.
And if you have listened to me carefully, I said we will use the National Reference Bureau data. So CT is only CT. There's no other CT.
This is the one with registering your ID.
Yes.
The National Registration Bureau.
Yes. so that way, we don't have many other databases. We are using one database. We are not creating our database. And we are telling you to use your ID as your identifier. I'm not giving you a SHA number. I'm just telling you, just declare your number and say, my ID number is 1022. That's it.
That's it.
Yes. Even when you are registering, that's what you register with. Because when you go to the registration portal, it just tells you ID and your data comes up. If you have tried, try, you will see. You say your ID number, it tells you you are so-and-so, 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 from this village, from this town, from this. Your data as it was.
Let's go to the phone lines because we had promised that we're going to let people speak to you. 0719 012 600. That's the number, okay? 0719 012 600. Let's go to the phone lines. Let's hear this. Good morning. Hello.
Hello. Good morning.
Morning to you. How are you doing?
My name, I'm fine, thank you.
What's your name?
My name is Dr. Darwin Ambuka.
Go ahead, ask your question.
Thank you. I have a few comments. I've been listening to Dr. Mohammed Abdi, the chairman, my fellow colleague, and most of us in healthcare actually are opposing SHIF. We are not pro-SHIF because of the sequence in which it has been laid down. First, talk about NHIF, which was established in 1966 and has grown over time. NHIF has grown to cover mothers, that is the Linda Mama. It has gone to cover school-going children as the Edwafia. It had expanded its wings to kidney, renal transplant, and dialysis. And we felt it was a fairly working system. Now, when SHIF was being brought in, it would have instead just looked like a merger. Why, one, create a very new system. If you look at how the SHIF was being set up, there are three funds actually. There is the primary health care fund, there is an emergency and chronic illness fund, and the social health insurance fund. And the first two funds, they are being catered for from the exchequer. Now the 2.75 of our gross is going to run the social health insurance fund. We got a problem with the tendering system of this fund. It was from single-sourced tendering system, and we've seen a lot of information, including a company called Apiero. Apiero is being run by one Gatabaki Judy, who's related to one of the people who are known in government.
Dr. Ambuka, sorry to interrupt you. You're going round now. So the main issue here, the main thrust of your issue is that you are opposed to this because of opacity in the process.
No, we're opposed to this because of the tendering system. Government institutions are supposed to have it's supposed to be a national tendering system, not a single source tendering system. That is one.
All right. Let's take that one. Let's take that one, Dr. Ambuka, because we have other callers on the line. Gregory, Nairobi, good morning.
Morning, how are you?
Very well.
Yes, I'm currently working in Mukuru kwa Ruben.
Okay.
The informal settlement to the marginalized people. I have two questions for Daktari here. How are the marginalized going to afford the payment for the poor? I mean, without a source of income, how are they going to afford this healthcare? Number two, is it an insurance fund or a social payment scheme? I mean, from my understanding of insurance is that you pay less to get more. But from this, it's like we're removing more money to get less. And the last one is there a 5-year budget plan, like after this, regime is out? What is the sustainability of the healthcare program? Thank you.
Yeah, thank you very much, Gregory. Biwot in Nairobi, hello. Nandi, Biwot.
Hello, sir.
Hello.
Yes, mine will be just very quick.
Go ahead.
I want to ask Daktari one question. When he was introducing his talk, he talked about fake news on this social health insurance fund. Now, what mechanism does the ministry have to counter this fake news? Have they partnered with the media houses so that this kind of fake news can be done away with? Now, another one is this kind of share. If I go to hospital, will I walk in and walk out without being asked any pay, the way some other insurance covers are doing?
Thank you.
Number three, what are they going to do with the retirees once they are out of the work? Will they transition them also to their retirement, whatever benefits, so that they don't get confused with this issue?
Thank you, Biwot.
That's my question.
Thank you, Biwot. Amos in Nairobi, hello.
Yes, good morning.
Morning.
Now, I have three questions. First is to tell the chair, the fake news normally comes as a result of lack of news. So when there is lack of news, then there is fake news. The problem we have in Kenya is always rushing. Even with the things which might be important, people always rush. I don't know what's the interest. Now, my question is, we've talked about the poor. the initial NHF we used to pay the installment, the 500 per month. Now this one, the fake news, I don't know whether it's fake news or it is the right news, you will be paying upfront. If you're paying 3,000, 300 at the beginning of the year, you pay 3,600. Now, how is it affordable to the poor, Mutabonabona and the rest? The second thing, I feel there is a fairness in contribution, that is okay. But in terms of benefits, there is no fairness. People are really struggling. Now, the dental, optical, the initial NHF, we never used to have them. We were paying less. Now that we are paying more, especially the employed, why are we still being punished by being given less? The last time I also attended a sensitization forum by their members, they talk of Linda Mama, and this thing was covering level 1 and level 2, that is free. But now when you go to deliver, which is most likely level 4 and above, or level 3 and above, you have to be a fully paid up member. So are these pregnant women aware, so that as long as they go for the clinic, they also need to pay so that they can deliver? If it is a fake news, maybe you can clarify.
Thank you.
If it is not, then I think we also need to know.
Thank you. Victor in Nairobi, before the doctor answers to these questions.
Yes, good morning, Lati.
Good morning, Victor.
Yes, the other day I was in Migori, my home county in Migori, Nyakige County. There is a place called Kadem, Apo Onger. I was asking around because I'm a pre-hospital caregiver, ambulance operation and others. So I was just doing my rough sampling on how much people know about the shift and, all these things around shafts. You can trust that most people don't know about this. And because I'm in an ambulance operation system, people are asking like, we've heard about, serikali inalipa, layman's perception that serikali inalipa. And I normally find a rough time giving that answer, because even for us, we don't have a clear answer. So kindly, if Dr. is in a position to make it clear on a primary, emergency and all that, how does it work?
All right. I think I can even start with that. Right? Just explain, how do those three funds work? When I go to a level 1, level 2 facility, do I go back home free, not paying a thing?
Thank you. So the three funds, the primary health care fund, the social health insurance fund, and the emergency chronic critical illness fund. So primary health care fund is tax funded. It's free. That is the one that comes from Treasury. You can access it in level 2, 3, and selected level 4s. Selected level 4s, one of them could be Loitoktok Sub-County Hospital, because there is no health center dispensary nearby in that town. So that's how we do the selected level 4s. So for that one, you don't need to, all you need to do is register to begin with. Just register. Star 147, yes, for SHA.
Okay.
Then you are entitled to that access.
And registration means pay?
No.
You don't need to pay?
Yes.
Okay.
Yes. You just register to begin with.
Okay.
And do your proximis testing. Then now, for you to benefit from higher services in level 4, 5, 6, then you have to go to, if you are unemployed, do your proximis testing, you pay your premium. Then now you have moved to the social health insurance fund. There, you have paid a premium. Then now you have access to those services.
Okay.
The third one is emergency chronic critical illness. So emergency is free whether you have registered or not registered. So that one you don't need any form of even registration because it's an emergency. There's no time to tell you register when you are bleeding.
Yeah.
So that one is automatic.
You go to any health facility.
Yes. Yes.
If it's an accident,
Yes.
you may be taken to the nearest facility, which will be in level 5.
Any for emergency. The chronic critical illness fund was supposed to address the issues when you have exhausted your tariffs at shift level. Now you continuously need services. because you have done your part in terms of your disease is not yet cured and you need to benefit, then now you move in, it steps in and reduces the burden. Okay. That was the idea, and it's also tax funded as well. For emergency, it has been in the Constitution from 2010, never implemented. It was in the
You're never supposed to be turned away
yes,
for an emergency.
It used to be never to be turned away by word of mouth, but there was no one who took up responsibility to pay. But now here we are saying SHA is taking up that responsibility to say we will settle that bill to the provider. Okay. So that is the thing.
Somebody's then just on the same line, I think Amos is asking about the expectant mothers.
Yes.
So you're going for clinic at Kimana Dispensary.
Yes.
And then when it comes to delivery, you go to Oloitoktok.
Yes.
Level 4.
Yes.
At Kimana, you went home. Oloitoktok, now they say this is a level 4 and it's a referral.
So it's if Oloitoktok is select level 4 hospital, then you don't need to pay because it's part of the primary health care.
Okay.
So your delivery is covered. And remember, I would say 60 to 70% of deliveries occur in level 2 and 3 facilities.
The dispensary.
Yes, and the health center level. So what, the issue of, now let me go back to each of the
So in
people.
this one, what we are saying.
Yes, you are not paying.
If you go to a health center or dispensary.
For delivery. All you need is to have registered. All you need is to have registered. That's it.
And this is with reference to government, public hospitals.
Even private and mission hospitals that have signed the contract for level 2.
And how will the citizens know which have signed? Ahead of time.
Ahead of time.
Yes, you need to know.
Yes.
So when you go for prenatal clinics.
Yes, you can ask the facility. Are you part of the SHA? Okay. Now you will advise me on how you want, other than saying SHA accredited facility. I don't know how else they will be able to communicate.
That communication department that I mentioned,
yes,
exactly is their job, because you are talking about 47 counties. You need to know. Okay.
Yes.
I am in Wajir. I am in Turkana. I am in Samburu.
Yes.
I am in Marsabit.
Yes.
I am in Tana River.
Yes.
Which hospital? The government hospitals are known, public hospitals are known. Which private hospital have you signed up with that I can go to?
So there are, even as it is currently.
It is that communication that I'm talking about.
Yes.
Okay? So that it is known. If it is budgeted for, let the public know where they can go ahead of time.
So there are a few ways to do that. One is the toll-free number, which should be able to guide you in your locality which facility is on the panel contracted. The second one is the facility to display and say they are SHA accredited. Then the third way is your branch should be able to tell you if you walk to your nearest branch or Huduma Center. But I fully understand your city because I'm not a communication expert.
No, you're not. But yes, imagine a situation when people were asked to public participate as they were on Friday.
Yes.
And they were told, all you need to do is look at the Gazette notice on this and this date.
Yes.
It will tell you where it is that you are actually supposed to go to public participate. Or look at our website. Look at the parliamentary website and determine from the website, depending on the county that you're from, where it is. I think you've understood my point.
And we have those two.
It needs to be communicated effectively.
Okay.
Whether it is through radio, whether it is newspapers, local vernacular. Yes. So that no one can say they have not been told.
Okay. Yes. I get you, and I think this is a challenge that I will take back to the communication department. They need to up their game when it comes to the issue of communication. I can't be a jack of all trades, so I don't know what they need. If it was a medical side, I would have given a clear explanation.
Let's take a break. You come back and respond to the rest of the questions, and then we pick a few more, all right? It's 18 minutes to 10. Our guest this morning is Dr. Mohammed Abdi. He's the chairman of the Social Health Authority. He's here to answer your questions and all the concerns that have been raised. Gregory, Amos, Biwot, Dr. Ambuka, all the questions are going to be responded to shortly. Do you think you need to visit a health facility near you? If you're thinking about a health facility near you, then Aga Khan University Hospital has answered that question, because they're saying, fear, worry not, stress not, we have facilities near you. 53 outpatient centers. That's a big number, City. And the Aga Khan University Hospital is saying, yeah, you don't have to come to the main facility for these outpatient services. We can actually get them there in all these 53 facilities. Just look out in your neighborhood. Do you see an Aga Khan medical center? Go in there. They will be able to sort you out in very many of the things that you need to do to get healthcare services. That's what they promise, and that's what they deliver.
This is the Situation Room, the only way to start your day.